going to do 2 at a time, as we have been doing recently, where we have the advanced EMTs and the EMTs together. So EMTs, as you hop on, understand that we are giving the lecture for the advanced EMTs. Yes, take notes. Yes, understand more. However, you're not going to be tested on things outside of your scope of practice. Just remember that. So as we go along, I'm going to go ahead and skip over these. Obviously, we're going to apply our fundamental knowledge to all of the things that we're about to find out. And I'm just going to tell you real quick, as you guys are reading through these slides, there are over 400 different things that can be wrong with the abdomen, okay? Okay, so Lewis did bring out a really important thing, and I wasn't going to say that, but yeah, basic slides only have 49 slides. This one is 95. You're getting double, okay, EMTs. So yes, but there are over 400 different problems that you can have with your abdomen, okay? And that's also including your GI and GU, which is your genitourinary or your renal system even. And there's so many complications. So at the end of the day, there's a lot that we do that's just kind of the same. When you see a patient that's in pain, we try to send them in a position of comfort. Advanced EMTs, you guys are going to start IVs as necessary. And we're going to rapidly supply as much diesel fuel as necessary to get them to where they need to go in case of a true emergency, giving emotional support to those as well. And guess what, guys? I just told you there's 400 different things that can be going on in the abdomen. And it changes when you have females because we add on a few more. We don't have to know the exact thing that's wrong with the abdomen. We can't, okay? Well, there's probably someone out there that probably does and has such a great way of learning and knowing what's going on, but without testing out in the field, you can't be 100% certain. And we don't have those kinds of sonography and other detailed exams. So what do we have to determine? We have to determine if they have belly pain. We need to determine where it's at, how long has it been going on, and we'll go into those as well. So that's what I want you guys to really focus on, is making sure that you understand your sample and your OPQRST questions. And I want you also to focus on several of the ones that we are going to talk about because they're the most popular ones out there. You're going to see these as you go throughout your career, okay? So AMP, the GI takes up a lot. You do have some hollow organs, you have some that are not. And when you don't have the hollow organs, when they open up in the abdomen, they cause some serious issues. Solid ones are mainly full of blood. So that's going to be like your liver and your spleen. When those open up, we have major shock that we're dealing with, okay? And you guys can look at this. Now, this is your digestive tract, and this consists from the oropharynx, the mouth, all the way to the anus. And its main function of your digestive tract is literally to absorb the products for digestive reasons and to fuel all the cells within the body. Remember, the brain can only has to have 2 things to survive. One is oxygen, the other one is glucose. Well, where do you think the brain gets the glucose from? It's here. This is where we break things down. Okay. Entire digestive process takes about 8 to 72 hours. And we're going to talk about, okay, real quick, super quick AMP lecture here. Salivary glands secrete saliva to help lubricate the food. If you don't have salivation, when you swallow, it gets very, very dry. Imagine eating the overcooked turkey at Thanksgiving along with the overcooked dressing and or stuffing, whichever one you eat. Okay, it's like a desert in your mouth, and it's really hard to get that, to swallow that down. And people are constantly taking drinks at the dinner table. You guys know what I'm talking about. You've probably been there, done that. So why are we drinking? Because we're trying to lubricate that to get it down. So salivary glands, they secrete that saliva to help with the beginning stages of swallowing. Okay, once it's swallowed, it's going to go through the esophagus. and then it's going to intertwined around the esophagus are veins that drain into a more complex series of veins, which join together to form the portal vein. The portal vein is important in a few minutes. I will say this though, I think we get a little bit more further into it later on, but this gives a direct venous blood supply to the lower GI, including even into the liver, and that way nutrients can be absorbed through that. And so it's going to go around, it's intertwined in all of this, okay? And even low amounts of pressure within this area can cause leaking and ruptures of these vessels, so that's really not good either. So let's talk about our stomach. It secretes hydrochloric acid, and that breaks down the food. Have you ever been laying down flat after you've just eaten and you're like, oh no, it's opening up, y'all, I gotta go get some Tums, this is terrible, and you have some acid reflux. That is hydrochloric acid, and that's really bad. It can erode over time. And this can, your stomach can stretch to many times its normal size. This is how people get from their normal size pants that they're supposed to wear to extra large pants, okay? Because of this right here. And there is something that's a, you know what, that's a paramedic thing. I'm going to keep going because I'll get into A&P. You guys know you got to rein me in. Okay, so once it stretches, it can stay there. It will stay at that size for a very long period of time until you train your stomach to go back to where it should be. And sometimes the stomach does absorb some materials, but those are going to be more like your water or caffeine, even some medications, and definitely alcohol. Your duodenum, and I've heard people call it the duodenum. I've always heard it called the duodenum. That's how I'm going to pronounce it, but you pronounce it whatever way you'd like. It is the first part of the small intestine, and it absorbs resources for the use of other cells in the body. So basically what that means is it's just that first place of absorption. And it is in the first part of the small intestines. Now it says where pancreas, liver, and gallbladder connect to the digestive system. So they're all kind of right there in that one little spot. And then your amylase is going to be your active, and it's an well, hold on. Amylase is excreted, and it breaks down your big starches into simple sugars. That way later on, you can have glucose and well, it turns it into sucrose and then into glucose. And this also, when this happens, it produces bicarbonate and insulin. Now, why are those important? Well, here's the deal. We're going to talk about it in just a minute, but insulin is the key to all the cells opening up to allow glucose to enter the cells in order for them to move and do things. Otherwise, we just don't do a whole lot. So that's why that's important. And bicarbonate is also important because it neutralizes your stomach acid there in the duodenum as well. And if you have questions as we're going through, I'm going to go through it pretty quick. So just drop them in the chat if you have some questions. Now, our liver also helps with digesting bile, okay, or by secreting bile. It filters out toxic substances produced by digestion, and it creates glucose storage, which is awesome. It also produces substances necessary for blood clotting and immunological functions, and we'll talk about that later on too. And that won't be this night; it'll be the next one. Small intestines. Now, this one's pretty cool. This is where a lot of stuff happens. All right, so it produces enzymes that turn chyme into substances that can be absorbed by the capillaries of the small intestine. So essentially, blood is filled with a whole bunch of different nutrients as it exits the intestinal circulation, and then it heads on to the liver. And remember, we're filtering out at the liver, okay? So you have additional metabolism of fats and proteins that take place, and blood is going to leave your liver. It's going to enter into the subclavian vessels right here. And then you're going to have your water-soluble vitamins that are also absorbed in the bloodstream for use by the cells in different sections. So you have your jejunum, And that comprises a large amount of the surface area of the small intestines and does much of the work. And then you have your ileum, and that is just that final portion of the small intestines. Now, this is where whatever wasn't absorbed first is now absorbed here, okay? And it's also going to get your bile acids, and it's going to return those to the liver for future use. And then you're going to have more vitamins like your B12 that help in making nerve cells and red blood cells later on. That's also absorbed right here too. And I'm going over this really fast. There's a reason for it. We just got to get through it. Okay, guys? So large intestine, or colon, if you will, your chyme is now considered feces because all the substances that have been broken down and absorbed, the only thing left are the waste products, and we call those feces. The primary role is to complete the reabsorption of water here. So when it first enters the large intestines, it's watery feces, so to speak. And as it continues to go through, it is going to continue to absorb all of that water and solidify that into stool at this point, okay? And then there's also bacterial digestion that helps here. Now, you have bacteria normally found within the colon that helps break down chyme, but you don't want to get that anywhere else in the body. That's why, and I'm just gonna say this real quick, that's why women wipe it a certain way than men. We have to wipe backwards because we don't want the normal floras to commingle, okay? And then you have attached to the last portion of the colon is the rectum, and you have a sphincter there called your anus. And that's where the feces are obviously dispelled from the GI tract. So now, spleen, this one's super important too. It has no digestive function at all. None, but it's still in the stomach because we don't know where else to put it, okay? But it's part of the lymphatic system, and it plays a significant role in the relation to red blood cells and the production, and also your immunological system, period, okay? It's going to filtrate your blood. It aids in development of RBCs, and it even serves as kind of a blood reservoir, which is another reason why when we have a splenic laceration in, let's say, some sort of traumatic injury, maybe like a seatbelt, that's really bad. Our patients can bleed out very quickly in the abdominal cavity. But it also produces antibodies that help fight off disease and infection. So it's really a great organ that not only helps with just blood production, but also the antibodies, okay? Now let's go to the genital system. It says the abdomen also holds the reproductive organs for females, of course, and we understand it also has for the male. So in the female, you guys can read these, you know what they are. And I'm just going to keep going because we're going to get further into those in a minute. The urinary system is going to be your kidneys, your urinary bladder, and of course the bladder is going to store your urine, and that's until it's released from the body, right? Your ureters, they help transport the urine from your kidneys to your bladder, and you can see that in the picture. And then your urethra transports urine from the bladder out of the body. Okay. So we have two main functions here. One is it regulates electrolytes, water content, and even acids in the blood. Yes, that's correct. So remember when we were in respiratory and we talked about if someone is a little too acidic and they're breathing, they need to breathe out faster because they're getting rid of the hydrogen ion. That can also happen in the level of the kidneys and the urinary system, and this is where this happens. Or it can hold on to bicarbonate, or it can release bicarbonate, or it can hold on to hydrogen, or it can release it. So it does several different things here for that. It also removes a lot of metabolic waste, drug metabolites, and excess fluid from the blood. So if you have someone who is a CHF patient, they give them medications to help them flush the excess fluid from their bodies. And what that does is it, through osmotic pressure, pulls from the bloodstream water, which goes into your urinary system to be flushed out. So kidneys are so super important, you guys, even though they're one of the last things that we think about sometimes. They perform all of these functions continuously, just like our heart pumps, our brain thinks, our lungs inflate and deflate. Our kidneys are some of the hardest working organs that we have, and it filters up to 200 liters of blood a day. In the chat, I want to see how many liters of blood does the human body have on average? I'm paid to be here till 10. Just gonna throw that out there. So I'll wait for y'all's answer. How many liters of blood does the human body have on average? Okay. Usually between 5 and 6. I think 6 is the standard. So good. Okay. Some of you guys are guessing. That's okay. That's why we're talking. It depends usually on males. They say 6 liters. I believe they say women is 5, but we're going to go with 6. Okay. So I'm going to do some math over here. I'm going to pull my handy dandy calculator up. 200 divided by 6 equals 33.3 times. 33.3 times a day does the entirety of the blood in your body go through your kidneys at one time. Do you understand how important the kidneys are? The answer is very, in case y'all didn't know. So it produces hormones that generate new red blood cells. Did you know that? Sure does. It also helps convert glycogen to glucose. And what I say the brain has to have to survive? Oh yeah, glucose. Okay. Then we have some nephrons, and those are inside the cortex. And these are the structural and functional units of the kidney that form urine. Without them, we couldn't have that. And when they're damaged, you don't produce urine, okay? Kidneys play a major role in maintaining homeostasis, including your calcium, magnesium, and phosphate balance. And that's important for you to know when you get to paramedic school. I promise you will want to know this. They also preserve the balance of eliminating metabolic waste products such as urea from the blood. And when these guys fail, your patient loses the ability to excrete urea from the body, leading to a condition called uremia. And if you see that in your book, you need to underline it and highlight it. You need to know that, okay? Once the urine does enter the collecting ducts, it passes through the minor calyx into the major calyx and then into the renal pelvis. And you guys can continue to read through this. I'm not going to kill y'all with all of these notes on the side. But I will say the beginning of the urethra, where urine is actually expelled, sits in the inferior aspect of the bladder. And there's a reason for that. It needs to be in the lowest portion of the bladder so that it empties fully, okay? If that makes sense. And I also will tell you that the brain exerts control over the urge to void. And when your bladder gets to a certain degree, it cannot go anymore, and it will go ahead and you'll urinate all over yourself whether you want to or not. But I will say this. So now we're going to pause for about 2 seconds and show of hands in here, how many of y'all run calls or have run calls? And then on here also, if you've never run a call in your life, go ahead and let me know. Okay, Rodney, I see your hands up. Okay, I'm going to say that that's a yes. How many more? Come on. Tell me in the chat box. I have a reason for asking. Okay, good. I got 3 of you. I'm going to start lowering hands now. Okay. Anybody else? Let's see. Let me go to my chat. Okay, I got some. Never been on a call. That's okay. Shaylin, I'm going to ask you a question then. For everyone else, okay, I've only been as a volunteer, but didn't do it. But you still got a call. There's a reason I'm asking for this. Shaylin, I don't know if this is going to help you or not, but I'm going to try. Okay, you ready? How many of y'all have been sitting down and need to go to the bathroom? You need to go urinate. But then as soon as the call drops, you don't have that feeling anymore. Go ahead. Put it in the chat box because it's all of you. Now, do we go ahead and try to force ourselves to go ahead and go to the bathroom real quick because we don't know how long we're going to be on that call and then shoot out the door? Yes, we all do that, okay? You're crazy pants, cuckoo bananas if you don't, because I could be on a call for hours, right? And there's no bathrooms out there. Okay, absolutely. Yes. Whole bunch of hands up. Yes. Do you want to know why? Are you ready for this? Now, remember where I said the brain exerts control over the urge to void? When the tones drop and we know there's an emergency, our fight or flight response from our sympathetic nervous system pops on and it says, hey, it's time for our heart rate to go up, blood pressure to go up, respirations to go up, our pupils are going to dilate, we're getting ready to go do stuff, right? Fight or flight. But our parasympathetic nervous system it's over digestion. See where I'm going here? It's also sex too, which is kind of weird when you think about it, because I'm like, that's not where my brain would go, but that's what it does, okay? So guys, it's over these two right here. So your parasympathetic nervous system is taken over by the sympathetic nervous system because your fight or flight response going to a call, hence why you no longer need to pee. You're welcome. I feel like firemen are different, always have to do it. Mark. Anyway, I thought that was an interesting tidbit, and I just wanted to share it with you. Now, we're going to get back onto this. I hope you guys learned something from that. Going back to blood kidney filtration, your pregnant patients will have 30 to 50% more blood, and that's absolutely right. So say mom's got 5 liters during pregnancy, she'll gain 1.5 more for a total of 6.5 to 7 liters. Little side note, kidney function is huge for these patients as well, and Bethany is 100% right on that one. I mean, 1,000% right. As a matter of fact, while we have such a trouble breathing sometimes because of all that, and not necessarily the excess weight or even the excess fact that there's a baby pushing on our diaphragm, is the fact that we have so much blood pumping through our system at one time that it takes a minute for us to take a deep breath. So a lot of your pregnant females, especially in the last trimester, they're going to be, you'll just be sitting next to one and they'll go, and it's because we're trying to reoxygenate that excess amount of blood. And our kidneys are filtering like nobody's business. It's crazy pants. Okay. Oh, I have that feeling at work. I'll be about to go to the bathroom, but then we get a bus and I'll have to take like 20 orders. There you go. See, that's exactly what it is. Thank you so much for finding a way to take that, Shaylin, and put it together, because that's exactly what it is. It's our fight or flight response. And it's like, oh, I got to go to work. I'll be better in a minute. Okay. But then as soon as you calm down, if Mark doesn't get to go to the restroom before the fire, as soon as you calm down, it's time to go to the bathroom. So you become hyper aware of your GIGU. All right, so patho, acute abdomen. And now we're going to get into some disease processes, guys. All right, let me take a drink real quick. All right. So acute abdomen is only going to refer to sudden onset of abdominal pain. And it's going to indicate that there is some sort of irritation of the peritoneum. So it indicates peritonitis. And what is itis? It's inflammation. So it's inflammation of the peritoneum. All right. And your peritonitis is just a thin membrane that lines the entire abdominal cavity. And this can be caused by, of course, infection. It could be a penetrating abdominal wound. It could be like a blunt injury, like, once again, I'll go back to the seatbelt, okay? It's a lot of different disease processes can cause this. Severe pain is your major symptom, and the major clinical signs are abdominal tenderness or distension, excuse me. All right. The peritoneum is going to consist of the 2 main membranes. And the first one is the parietal peritoneum, and that lines the walls of the abdominal cavity. And it has the same supplied by the same nerves from the spinal cord as the skin overlying the abdomen. And the reason that this is important is because in that nerve, you can perceive pain, touch, pressure, heat, and cold. And so that's why this is different. Those sensory nerves can easily identify localized to a point of irritation, okay? Whereas the visceral peritoneum, it covers the surface of each organ in the abdominal cavity. Now, it's supplied by the autonomic nervous system, and it's stimulated when distension or contraction of the hollow organs activates the stretch receptors. This sensation usually is interpreted as colic, a severe intermittent cramping pain. So if you can point to your belly and it hurts, that's going to be your parietal perineum, okay? Peritoneum, rather. If you kind of know, like, oh gosh, it's cramping. Oh, it's my stomach and it's cramping. Men and women both have stomachs that cramp because they're about to go vomit, okay? This is what that feels like. That is your visceral peritoneum that covers the surface of each organ, okay? It's covering the stomach. It's covering the spleen. It's covering the liver. It's covering the pancreas, okay? Whereas your parietal is covering everything. And it's supplied by those same nerves that cover the skin. So I hope that makes a little bit more sense. I wish somebody had slowed down and told me that when I was going through EMT or EMT the first time, because I didn't understand it. So I went ahead and went over this one. Visceral pain usually occurs when the receptors in the hollow structures are stimulated. And so that's why you're going to get that. That's mostly associated with your urological problems, like your urethra, bladder, things of that nature. Okay. But pinpointing it can be really challenging because you just don't know. So we take it, hey, they're in pain. That's all I need to know. Okay. Now let's talk about referred pain. Now this one's a big one. You can have referred pain on several different reasons, but it's a referred pain because you're feeling pain elsewhere in the body. As you can see right here, you have your gallbladder is hurting, but on this guy right here, he's got shoulder pain. And it's because it's on that same line, so to speak, okay? So you have some sort of a distant point, such as your back or your shoulder, that is going to have a synapse point where it will move from one place to the other. And you can even have this after having surgery, and this is a personal thing. When I think it was my third C-section. I've had 4 C-sections. And my third one did not go well. And they ended up pumping more air into my my stomach than had been before. And that wasn't what was wrong or what the issue was. But in this particular case, because of the issues that I had more air in my stomach. Well, after you've had an abdominal surgery, the ability to pass gas is extraordinarily hard. But because I had a gas bubble stuck in my belly, I had pain that was shooting pain in my left shoulder. I thought I was dying. And the nurses, they couldn't help. They couldn't do anything. And I finally texted 5 of my best friends and I said, whoever brings Gas-X to me first, because of course they wouldn't give me anything, whoever brings to me first gets $100. I didn't have $100 and all 5 friends showed up at the same time. So I gave them ice cream later. But suffice to say, I got Gas-X and I was fine afterwards because I understood that the reason that my left shoulder was in such pain and every time I breathed deeply, that it was a referred pain that I was getting. And the only reason I would have known that was because of this particular lecture. Okay. All right, peritonitis. This is typically causes ileus, and this means that the stomach can only empty itself through emesis. And this is where it's just a paralysis of the muscular contraction that normally propels material through the intestines. And we call it peristalsis. And when that begins is when you immediately swallow the very first time, you have a peristaltic wave that moves from the tongue literally all the way through every single bit of the intestines, all the way to the anus. Not my C-sections, but a laparoscopic hernia surgery was the worst abdominal surgery I've ever had in my life. Pain was, yes. By the time I had my 4th C-section, I was up doing laundry day 2 from being home. It's fine. So you just kind of get used to it. Okay, thank you, Deborah. All right, so this is going to be, by the way, just let me back up. We talked about our peristalsis, but when it happens, when you can't empty your stomach, it's because there's no peristalsis happening. So emesis is vomiting, in case you don't know. If you do not know that, you need to underline it, highlight it, and know it because it's going to be called that from here on out. Now, peritonitis is associated with a loss of body fluids into the abdominal cavity. So that just kind of abnormally shifts fluid from the bloodstream into the tissues. And that's going to decrease our circulating blood volume. And we're going to get hypovolemic shock, even though our patient's body fluids, they're still there. They're just in the abdominal cavity, but they're not in the bloodstream. And if they're not in the bloodstream, then we're not getting oxygenation. We're not going to get glucose to the organs that desperately require it. So we're having a problem, and hypovolemic shock is a big deal. So we can just continually compound all of these until a point where your patient is really bad off, okay? So you're going to really check on those vital signs and continue to check for signs and symptoms of shock, okay? And you may or may not have fever with these, by the way, okay? Now, let's talk about patients with diverticulitis or cholecystitis, which that's the inflammation of the gallbladder. They may have a substantial elevation in temperature, and that is because that is an infection. Once that the appendix ruptures, an abscess is going to begin to form inside of your abdominal compartment, and that is seriously bad for your entire overall well-being. And so we have to really worry about our appendicitis patients, right? That is a true emergency. So your pre-hospital care, I'm just going to go ahead and tell you real quick, for many of these is going to be supportive. You just need to have that ability to recognize and differentiate between the two, or between the most common ones. I will say that. Now, I will go ahead and point you to table 20-1 in your text is going to have the most common locations of direct and referred pain. And then there are so many different things that are we talk about. Just go ahead and go to table 20-2 and look over those conditions, because there's so many. And that's right here. You have your appendicitis, you have ulcers, diverticulitis, hernia, and I could just read a few of those. So I'm going to go on to the next one. Okay. So let's talk about causes of acute abdomen. And it doesn't mean it's gorgeous. It's acute, meaning it comes on very quickly. Okay. Entire abdominal cavity normally contains a very small amount of peritoneal fluid, and that pretty much bathes and lubricates all of our organs so that they are able to move. Remember, we talked about that peristaltic wave? Could you imagine having the peristaltic wave in your mouth when it feels like a desert? No, we don't like that. So we have a little bit of peritoneal fluid inside the abdominal cavity for the exact same reason. Okay, thanks, Lindsay, for letting me know. Any condition that allows pus, blood, feces, urine, gastric juices, intestinal contents, bile, pancreatic juice, intestinal contents, and I'm keep going here, inside for any of that foreign material to accumulate within or adjacent to the abdominal cavity can cause peritonitis and acute abdomen. So what does that mean? Essentially, hey, duodenum, stay in your lane. Hey, gallbladder, stay in your lane. Hey, spleen, stay in your lane. And everything stays in its lane, in its own little spot, okay? When it doesn't, we have acute peritonitis, okay, or acute abdomen, and it causes peritonitis. So you can have retroperitoneal pain that's behind the peritoneum, and that's going to be structures like your kidneys, your ovaries. So think about it this way. When you have a kidney infection, it doesn't hurt in the front, it hurts in your back, which is retro, behind, peritoneal, okay? And there's some other structures that go back there too. All right, moving right along. Okay, GI hemorrhage. Bleeding within the GI tract is a symptom of another disease, and it can be acute or it can be chronic, and there are several different reasons for those. All complaints of bleeding should be considered serious. And there are some causes of GI bleeding that's in table -20 or 20-3, so look those up. You can have upper or lower GI tract bleeds, and the upper GI tract spans from the esophagus to the upper part of the small intestines. And I wanted to tell y'all what that, I just lost it. Pyloric sphincter is the exact spot where it stops, but I digress. If you have bleeding associated within your esophagus, it can be an esophageal varices. It could be a Mallory-Weiss tear. If it's a Mallory-Weiss tear, that's going to be a lot of bleeding. And you're going to see hemoptysis, okay? And it looks like hematoemesis. So heme meaning blood, emesis meaning vomiting. So, vomiting up blood, all right? And that you can see that with a lot of patients with your upper GI bleeding. And sometimes it's going to be frank red blood. Sometimes it's going to be coffee ground emesis. And depending on what it is going to depend on where it comes from. So the lower GI tract spans the upper part of the small intestines all the way to the anus. Common causes are going to include like your bowel inflammation, diverticulitis, some cancer, and even hemorrhoids. And this often manifests as melena, which is going to be dark, tarry stool. It's almost black, and it's very foul smelling. So be wary of that. So when you have someone that says that they've been going to the bathroom having a bowel movement, ask them to describe what color, or is it abnormally foul smelling or what? Because they can, of course they'll tell you. Then you have esophagitis, which is inflammation of the esophagus, and that's just irritation and swelling. And you guys can read more about that. But you can have, I will say, esophagitis is usually from reflux that you get because the stomach acid, the hydrochloric acid, is coming up and it's irritating and it's taking away some of those layers of skin as it comes up, right? Because it's acid. Okay, so GERD. This is a condition. If you have acid reflux one time, you do not have GERD, okay? I don't want anybody going around saying, oh my gosh, I have GERD now. No, it's a condition, all right? But it's a condition in which the sphincter between the esophagus and the stomach opens, allowing the stomach acid to move superiorly, so move upwards, right? And it's also called acid reflux naturally. And remember when I said, like, if you lay down your head down flat, like under like one pillow, and that's it, maybe 10, 15 minutes after eating, and you suddenly get this issue? That's part of it. You're just allowing your stomach will just open up. So after you've eaten, give it about half an hour before you go lay down, and that'll help with that issue, okay? Unless, of course, you have GERD, and then that's a whole different story, okay? But it could result in weakened portions that are more susceptible to bleeding. And it can cause, I want to go over the causes of smoking, obesity, and pregnancy do increase your chance of GERD. And it can cause, obviously, heartburn, because we understood that. So heartburn can increase the susceptibility of bleeding in those weakened areas of your esophagus, and bleeding can happen with hemoptysis in long-term levels, okay? PUD and gastritis, peptic ulcer disease. What happens if the bowel has a fishy smell with mucus and diarrhea? I would say go see a doctor, because I don't know the answer to that one. My dad has it from when he was in the military. Yes. So PID is something separate. PUD is peptic ulcer disease and gastritis. The stomach and the duodenum have high levels of acidity inside of them, right? So it can result in ulcers on the inside, which are essentially just abrasions on the inside of this area, okay? So to prevent damage, protective layers of mucus line both organs, but in a peptic ulcer disease, that protective layer just kind of erodes over time and allows that acid to eat into the organ during weeks, months, years, whatever. And so the gastritis is caused by that same imbalance between the stomach acid and the protective layers there. So gastritis is the pre-ulcerative state, and it's where our stomach is just inflamed. There's no erosions yet, okay? Peptic ulcers are usually the result of Helicobacter pylori. I can never say that. H. pylori, because everyone calls it H. pylori, guys. It's an infection that gets into your stomach. And then you have, you can get that even from chronic use of non-steroidal anti-inflammatory drugs or NSAIDs. And that's going to be like your ibuprofen, your Tylenol, okay? So watch those. So overuse of those can cause this issue, okay? And then alcohol and smoking does the same thing. And that's just over and over and over abundance of use, okay? It does affect men and women equally, more frequently in the elderly. Why? Because they have frequently taken NSAIDs all over, their life. The pain is going to be more of a burning and gnawing, and it's in the upper abdomen and just below the sternum. So it's going to be like right there where your kind of where your diaphragm is, like just kind of right in that area. That's where you're going to feel it. You're going to have your nausea, vomiting, and belching, and some heal without any intervention at all, which is really awesome. But if you have some bleeding, then that's a complication that could be from a perforation. And we definitely want to go to a hospital at that point, because when we have a perforation in an organ, there's a whole bunch of different things that can go wrong besides just having an upper GI bleed, right? So that's going to be a patient that's not stable because we can't see inside, right? Mallory-Weiss tear. Let's move here and talk about, this is a tear in the junction between the esophagus and the stomach. This is bad. This is severe bleeding is going to take place here, okay? Okay, my gastritis feels like a heart attack when it flares up. Yeah, I bet it does. Yeah, and that was kind of what I was saying. Bethany, thank you for answering that. It is definitely normal to have small amounts of mucus, because that is going to be part of that that comes through with your fecal matter at the end of a bowel movement. But if it has some sort of an extra smell or there's something else there, then definitely go to a doctor and get the stool examined. Talk to them first, obviously. I'm curious to know if anyone remembers which dermatomes are around the diaphragm from last lecture. I know. I mean, I taught it. That's probably why I know. But Bethany wants to know, and I want to know if y'all remember. I don't think that that's normal, Deborah. I would have that checked out. Okay, I'm here till 10. Bethany has a question in the chat box. She is curious to know if anyone remembers which dermatomes are around the diaphragm. I have one person, one brave soul. I'm gonna go ahead and tell you guys. When I went through nursing school, you guys can keep answering. Come on. When I went through nursing school, I had an instructor. He said, if you're gonna be wrong, be boldly wrong. Okay. Y'all are sitting here typing. Nobody can see y'all except for y'all see me. That's it. Okay. So be boldly wrong if you want to be boldly wrong. All right, Bethany, did you want to add something to your question? I kind of feel like I know where you're going, but I don't want to step over you.
No. I just basically wanted to kind of, I guess, re-emphasize that how important the dermatomes are, and that, hey guys, this will be a test question at some point in time, whether it's like on your like upcoming exam or whether it's on your national registry. This right here is one of the key points. We're just trying to drive that home. That's all.
Absolutely. Thank you so much, Bethany, for pointing that out. And you guys, we have to pull things from other places, just like we talked about the respiratory system and how we are able to immediately change the breathing rate, depth, and quality to help us with our hydrogen ion or our bicarbonate. The kidneys are not the same. It takes about 4 hours for that to begin to adjust. So we're taking from other lectures and we're pulling and we're putting everything together, okay? So one of the primary risk factors for a Mallory-Weiss tear is alcoholism and eating disorders. So let's talk about eating disorders here. You ready? If they vomit a whole lot, that's going to erode that area. And so that junction between the two of the esophagus and the stomach is a lot thinner than the stomach and the esophagus, right? So it's going to tear eventually, and that's what they're talking about. And then alcoholism, exact same thing. It's going to eventually erode that area. Now, when they start vomiting blood, when the hematemesis begins, it can cause such severe bleeding that your patient can die. Okay, so this is a very big thing to go. In women, this syndrome may be associated with severe vomiting related to pregnancy too. So please don't misjudge and just be like, oh, well, they have an eating disorder. It could literally be from multiple pregnancies and they're pregnant again and they don't know it, and then they have a Mallory-Weiss tear, okay? The extent of bleeding can range from very minor to extreme severe with extreme blood loss, okay? So be ready for shock. Okay. Borhave syndrome, this also occurs during vomiting and is similar to that Mallory-Weiss tear. Yes, they absolutely will with throwing up blood. Yes, especially if it's a good amount. So you'll see your shock symptoms, signs and symptoms at that point. Oh, okay, good. So what happens is it creates a passage for blood, air, and food out of the esophagus into the mediastinum. And this does occur more often in men than it does in women. And it presents after a large meal that can include alcohol, okay? Esophageal varices. We had our Mallory-Weiss tear. That one's really bad, right? And that's because of alcoholism and vomiting, all right? Esophageal varices is different because it's about the amount of pressure within the blood vessels surrounding the esophagus. And when that increases, we have a varices. And essentially what happens is the blood vessels will eventually deposit blood into the liver. And when that's blocked into the portal vein, the vessels, those are going to dilate, causing the capillary network of the esophagus to begin leaking. And when that leaks, we have a massive change in pressure. I'm trying to catch up over here on the side while I'm talking at the same time. So hold on. Yes, esophageal varices, you can bleed out from esophageal varices also. And so in industrialized countries, alcohol is the main cause of portal hypertension. So what happens here is you get portal hypertension causing the esophageal varices. And it's going to take on two different functions or two different forms here. Usually it's liver disease, okay? And you're going to see in liver disease, you're going to see fatigue and weight loss, jaundice, anorexia, edema. You're going to have abdominal pain, nausea, and vomiting. And so that's going to be your cardinal signs. But it could take up to, months to years before the patient even feels bad. And even further, they may not ever even know that they have this issue because they don't know that they need to go to the hospital to get that particular thing checked out. So when you have a second presentation, usually when the rupture of varices happens, it's really sudden, super, it's difficult to swallow, very painful. You're going to have bright red blood. Pardon me, hypotension. And this is where you're going to have your signs of shock. Okay. And so you just have to realize that those damages to the vessels can be life-threatening. And so you have to be very, very quick to get them to the hospital. So let me catch up over here. Can it cause liver failure? Yes, it can. People will code in front of you if esophageal varices are bad enough. Yes. My patient almost died. He was close. Yes. Deborah, to your question, when there is a significant blood loss, yes, it can cause liver failure. Yes, and it does because of the fact that it's going to significantly change the liver function itself because of the fact that there. Hold on just a second, guys. I'm getting interrupted by a 4-year-old. My apologies, you guys. Yes, my babies are always up under me. Sorry, guys. Oh, thank you guys. I appreciate that. I will say that a major rupture with esophageal varices, guys, your patient can be dead within minutes. Okay, so esophageal varices is nothing to, you don't play around with that one. hemorrhoids. There are people that are like, oh, hemorrhoids really isn't a big deal. It's very, very common. You can have bleeding from that. I'm trying to keep up with you guys in the chat so we can get through this. Give me time to respond and I'll do what I can. Thank you so much, Bethany. I appreciate it. If you can help me out in the chat, then I'm just going to try to get through this as much as I can. I am going to take a break after hemorrhoids because I need to rest my voice because I'm starting to cough, okay? So, yes, she is, Lindsay. We love Bethany. Okay. This is created by swelling and inflammation of blood vessels surrounding the rectum. Now, why do we have hemorrhoids? Does anybody know? Put in the chat. Obviously, you can look on the side over here. It's from conditions that increase pressure on the rectum. What are those? I just want one thing. Okay, that is one, but why? Why are they pushing the stool out? Starts with C. Constipation, lack of fiber. Okay, lack of fiber is also the reason. Joshua, that's good. But constipation is what I'm looking for. You can get them from pushing too hard. Yes, you can get them from pushing too hard. Even giving birth, yes, all of those. You already know who I'm looking at this way. Don't laugh. Okay. Constipation, that's right. And yes, Deborah, I kind of figured that was what you were meaning, but yes, constipation, not having enough fiber in the diet, or having too much iron production in your blood because you are pregnant. That's another one. So pregnant women have a lot of hemorrhoids, okay? So just gonna throw some extra things out there for you guys. So, pardon me. All right. It's going to have bright red blood during defecation and during wiping. It does. Diarrhea does also cause it to be to get irritated and can even cause it to open up. And if you do have bright red blood during defecation, that is called hematochezia. Okay? Hematochezia. I don't need any. Mark, stay out of the chat. Okay? Just no. All right. Hematochezia. It is underline it, highlight it. You will see this again. I promise you. Old age absolutely can do it as well. Yes, you can, because over time you have caused so much tension and so much pressure on the rectum that it will push the hemorrhoids out. And you can have internal hemorrhoids as well. They don't all have to be external. It is minimal bleeding, easy to control, but they're going to have some itching and even maybe a small mass on the outside of the rectum. And if that happens, all you're going to do is you're going to take maybe an ABD pad or a few 4x4s, hand it to your patient and tell them to put it there. That's all you can do. Okay. Let's go ahead and take a break real quick. Let me turn on my handy dandy stopwatch for 10 minutes, and then we're going to start on gallstones. Guys, I'm only on slide 35 of 95. We got a while to go. So when I come back, I'm going to talk to Bethany during the break, and we're going to get a game plan, okay? Okay, Deborah, that's fine. I totally understand. If you need to go immediately, that's fine. So she and I are going to talk during the break, and then we're going to try to get you guys through this a little bit quicker, okay? All right, guys, let's go ahead and start that, the clocks. 10 minutes, guys, 10 minutes. Okay, guys, sorry about that. Now, just to do some real quick housekeeping, since we're back, to help me get you guys through this chapter before 10 p.m., Bethany has so graciously stated that she would not mind at all to answer any questions that you might have in the chat. So as I continue to teach, please do not think that I am ignoring you. But Bethany said that she will type as fast as she can so that you guys can get the answers that y'all are so desperately asking for. And I absolutely trust Bethany infinitely with all the information, her being a flight paramedic and having all the years of Sorry. My husband is texting me and he doesn't need to be. I'm in the middle of class, guys. Sorry. But Bethany is going to take care of that. She's got years of experience. I absolutely trust her, as you guys do too. I mean, you guys love her too. So I'm going to go ahead and start with the lecture. And then once we get to like a break, and I'm still going to ask you guys to put things in the chat and I will look for those, but then that's about it. Pardon me. All right, guys. So let's go over gallstones. I have had a cholecystectomy, which is the removal of the gallbladder due to gallstones. A lot of people in this world have that same issue, okay? But what does the gallbladder actually do? Well, it stores digestive juices and waste from your liver. So it's really big on taking out some of the nasty stuff, right? But gallstones can form and then they can block this outlet. And when they do that, that blockage is going to cause, number one, pain, because there's going to be a backup of the nasty, right? And sometimes that blockage is going to go ahead and pass, but then it's going to get back again. And what happens when we have too much of the nasty inside of an organ? Well, it causes inflammation. It causes an infection or an itis. So now we call it cholecystitis, and that's going to be considered the severe inflammation of the gallbladder. So in severe cases, your gallbladder can rupture, and when that happens, that spreads all that nasty throughout the area. That's really bad. It's not as bad as like appendicitis, because when the appendix bursts and ruptures, that level of nasty is a lot worse than the level of nasty from a gallbladder, but still yet it's not good, okay? Now, when it does spread, it can go to such surrounding structures like the diaphragm and even the bowel. And so what you're going to have is, and this is important for you to know, okay? If you want to know when you're reading a test question rather, and it says, well, how do I know if it's a gallstone versus this or whatever? Here you go. So presents as a constant severe pain in the right upper mid abdominal region and may refer, that's pain referment, by the way, to the right upper back, the flank, or even the shoulder. Remember the guy from a few minutes ago? Remember that one? He had the referred pain? That's this guy, okay? So remember, the pain may steadily increase for hours. It can come and go. And I'm going to tell you another way to know this very quickly. Underline it. Hold on yours. 30 minutes after a fatty meal is when it usually happens. So if they're on an empty stomach, and you'll see this a lot in gallbladder patients because they know better. It's like breathing hard when you have a problem in your lungs. You don't want to really super inflate your lungs. You want to keep it normal, like low, so it doesn't cause pain, right? Same thing with gallbladder issues. They'll go all day without eating because they don't want the pain. And then within 30 minutes of eating, especially something that's fatty, and trust me, there's a lot of fat out there that you don't know that you're getting in your diet until you have gallbladder problems. And then you say, oh yeah, that's fatty. So that's what happens 30 minutes after a fatty meal, and especially at night, that's when you're going to get some of these symptoms. And some of them are, and you guys have already read them, that's that bloating, gas, and belching and indigestion, but you have some nausea and vomiting along with it, and that referred pain is a big one, okay? Okay, so pancreatitis, this one is going to be inflammation of the pancreas, and we know that it forms digestive juices, but it also is a source of insulin in the islets of Langerhans, okay? So it's a very important little organ that's like, it's like this, it's weird shaped, okay? It's kind of like Italy, but sideways. I don't know where that came from, but you're welcome. So when we have inflammation of the pancreas, it is obviously called pancreatitis, and this just is caused by including obstructive gallstones and alcohol abuse. And that's really all I'm going to get into on this one. I'm not going to get into the whole alcohol abuse part, but if you have gallstones that are also obstructing the pancreas, that gallbladder's got to go. So if you also have severe pain in the upper left and right quadrants, often radiating to the back, look for pancreatitis. Nausea, vomiting, abdominal distension, tenderness, even severe pain. Remember, it's going to radiate to the back. And so what are some of the complications? Sepsis, of course, hemorrhage may occur, and look for fever and even tachycardia in these patients. So if you're looking for like what defines which one, write those down. Appendicitis, this one is going to be that little small recess in the large intestines, just kind of over on the side. And it's, it's an inflammation or infection of the appendix, and it can result in abscess, peritonitis, or shock. And when it ruptures, it's going to cause a lot of pain. When it ruptures, initially, it's dull, diffuse pain. It's just kind of there. It may center in the umbilicus area or in the umbilical area, if you will, and then pain later localizes to that right lower quadrant, okay, that may also cause referred pain. Your patient, they're going to have the nausea, vomiting, anorexia, fever, chills, rebound tenderness. Now, what is rebound tenderness? Rebound tenderness is simple. You push down on a patient when we're feeling of the abdomen, okay? You're going to do it in kind of a rocking motion. You're not going to go super deep. We don't do that, okay? We're just going to go topical and just kind of roll our hand around to see what are we feeling under here? Is what we're feeling under here hard? Is it soft? Is it tender? Is it not tender? If you're having abdominal problems, do you want somebody coming over and pushing real hard? No, you don't. So we're going to do a tender rock back and forth kind of. And then when you release, they say, oh, that hurts. Okay. That is rebound tenderness. You rebound and now there's tenderness. Okay. And that's going to be your classic result. Okay. So patients are going to feel pain upon pressure when the release. Women who are pregnant may not exhibit these symptoms at all. Okay. They may have a whole different idea. Okay. Gastroenteritis. This is going to be just a family of conditions, and it's caused by bacterial and viral, and it's typically because of contaminated food and water. And what you're getting there are going to be the nausea, vomiting, and diarrhea that you get from, food's not cooked well enough, or it's been contaminated by different things. It may also be even from non-infectious conditions, okay? And usually this is going to be like your diarrhea is going to run from 2 to 3 days, even if it's just several weeks until you get rid of whatever that is out of your system, okay? So be wary that you could have a patient in shock because of vomiting and diarrhea. That's 100% a thing that can happen. And your diarrhea can even have blood or pus in it, so please be aware of that. You can have what's called large dumping type diarrhea or frequent small liquid stools. Abdominal cramping, remember we talked about that being visceral pain, nausea, vomiting, diarrhea, anorexia. Anorexia is no more eating, okay? Like that's the absence of eating, okay? And if diarrhea continues, we're going to have dehydration, okay? And then it will cause more of a shock, okay? Now, diverticulitis, hold on, I got sidetracked over here. Okay. Diverticulitis. Now this came about 1900, and the reason for it is because when we got to the industrialized era of the world, we started eating things that we didn't eat before. And what happened in industrialized society is we started manufacturing food at such a great number that we were no longer home making things like we did before. So what happened? Well, fiber decreased because of that. We're not using enough fiber in what is being shipped out, so to speak, in like the boxes and now cans and everything else. So when that happened, we know that fiber is one of the things that we have that we need in our bodies and our digestive tract to help move fecal matter through our digestive tract, okay? So when you take away fiber consumption, what happens? Well, we have constipation, but we also have something called diverticulitis, and that is the consistency of stools became more solid, and because of it, more intestinal contractions are required. So what happens? The pressure in the colon is going to increase over time, and that's going to cause these bulges in the colonic walls, okay? So what happens when we have these bulges? So you have like a normal tube, and I mean, of course, it has, you know, the tube as far as the colon is concerned is like this, right? But let's just say it's a straight tube for S's and G's here, okay? And you guys can fill in the blank for S's and G's, right? So we have a tube here, but now we have all this excess pressure. And so we have a little pop-up of a little bulge right here. Well, what happens when we're going to the bathroom? Or, hey, we have these little pouches, because that's what it is. It's a pouch. And by the way, the pouches are called diverticula. Diverticula, you need to know that. Okay. Fecal matter gets caught in those bulges. Well, what happens when something gets stagnant in our bodies? Does anybody know right off the top of your head? Can you put it in the chat for me? What happens if something becomes stagnant in our bodies? And there's a whole bunch of answers that you could answer this way, but I do want to say infection is definitely one, okay? And absolutely infection. And if it's blood, it's going to be a clot, okay? So infection is it, all right? So now we have bacteria, because remember what fecal matter really is. It's all that other nasty that we're getting out, right? Well, bacteria forms, and it's going to cause the localization of inflammation and infection. And so that's going to cause even more problems. And your signs and symptoms are going to be blockage. Yes, very good. And it's okay. I can't spell either. Abdominal pain, fever, malaise. If you don't know what malaise is, if you just don't feel good and you just don't want to move, that's general malaise. Okay. And it's just kind of a overall not well feeling and not wanting to move. Okay. Some people call that lazy. It's not. Your body is saying, hey, I'm not doing a whole lot today. And by not doing a whole lot, we'll go to the bathroom maybe at some point. Eating is out of the, we're not doing that today. We don't have enough energy to do that. We're just going to lay down and just be there. Okay. So, body aches, chills, nausea, vomiting, and bleeding can happen. Okay. Ulcerative colitis. This is another big one. You're going to see this called UC. Okay. And this is a cause of inflammation, can be unclear in some of these cases. So the inflammation is generalized, and so it affects the inner lining of the intestines. It does not occur in patches like in Crohn's disease. So Crohn's disease is a certain section of your colon that is having an issue. Ulcerative colitis is the whole thing. So, so that one's even worse, and it results in a weakened and dilated rectum. And so what are some of the causes of it? Well, like I said, it's unclear. It can be stress related. It can be autoimmune, and sometimes it is genetics. So what does this look like? It's going to be your bloody diarrhea. You're going to have joint pain, even skin lesions, okay? Approximately 238 people per 100,000 have UC, and this is often seen more in women or in men than it is in women. There's usually a very strong family history because of this disease. So essentially what happens, we have that gradual onset of the bloody diarrhea. Remember hematochezia? You need to write that down. Then you're going to have that mild to severe abdominal pain. Now we're going to move on to the joint pain, then the skin lesions, and then you're going to have that complete loss of appetite because of the infection is set up. You're going to have the fever, that general malaise, and then you're just go to the hospital. That's where we're at. Okay. IBS. A lot of people have IBS. That's going to be irritable bowel syndrome. And this is a condition in which patients have abdominal pain and changes in their bowel habits. The patients can have pain for at least 3 days per month for at least 3 months in order to be diagnosed with IBS. So here are 3 main factors observed in patients. 1, hypersensitivity of bowel pain receptors. 2, hyperresponsiveness of the smooth muscles in the bowel. And number 3, the psychiatric disorder connection and IBS. And we're not going to get into the psychiatric conditions there, but there are some. It is unclear if IBS causes the psychiatric disorder or vice versa. I will say that. But spasms cause constipation, and if they stop that fecal movement, or it can cause diarrhea if the spasms are more wave-like, okay? I did not know that, Lindsay. Thank you. IBS can be triggered by stress, large meals, and certain foods, such as wheat, rye, chocolate, alcohol, milk products, and caffeinated drinks. I need to take a small break. I have a child with an ice pack. 2 seconds. Oh, sorry about that, guys. Okay, your patients are going to be will present with your abdominal pain and discomfort, but the pain is going to be relieved by a bowel movement. That's essentially what happens. Yeah, right, Deborah. So you may have stratorrhea. I'm sorry, I said that wrong. Oh, I can't pronounce that. 2 seconds. Nope. Bethany.
What you got? Where you at?
I went it's statorrhea. It's the one that's the really oily diarrhea.
Okay,
I can't remember how to pronounce it. Anyway, it's in your book. I guarantee it's in your book, guys. It starts with an S. I guarantee, but it's where it's the oily diarrhea and fecal matter that comes out. So it's not from the food. No, it is from the intestines. That's where it comes from. It's not from your food, Mark, which is crazy.
Pronunciation. I'll let you know.
Okay, thanks. But it's very foul. And it's just really not nice. And you're going off. You don't even know what I'm trying to say here. So don't worry about it, Bethany. I appreciate you even trying. I was like, well, maybe she knows right off the top of her head, but I can't remember how to pronounce it. I just remember I can look at it and I know what it is. Okay, so let's move on.
I just figured it out. The steatorrhea.
That's it. I can never say it.
I'm just sounding it out the best I could. I was like, where's she going with this? Hold on. And then I was like, and then as soon as I saw it, I realized what you were saying, but steatoria, I guess. Maybe?
I guess. I'm going to put it in the chat. You guys can figure it out. Somebody go to Google and figure it out for us, okay? All right, so let's move on to Crohn's disease. Sorry about that side quest I had to take. Okay, Crohn's disease. This is going to be similar to your ulcerative colitis, but can involve the entire GI tract from mouth to anus. So it's not just one. It's not just one little small part. It can be literally from all the way down. And what that is going to cause is ileum. Remember, we talked about ileum. That's the one where it just stops everything, right? Okay, there's no definitive cause. There can be family history and genetics. Presence of signs and symptoms outside of the GI tract they do happen. It is in 201 adults per 100,000, and most of your patients are between age 15 to 35. Usually you're not going to get anyone that's in the geriatric population, but every now and then you will. It is mostly in Caucasians rather than African Americans, and people of Jewish descent have had a notable increase over time. Okay, so it could be autoimmune, could be family. There's a whole bunch of could be's in here. Okay, so your patient is just going to present with a chronic complaint of abdominal pain, often in the lower right area. And the disease just results in a series of attacks by the immune system on the GI tract. Okay, steatorrhea. That's what we're going with, Lindsay. Steatorrhea. Thanks. Okay, so let's go for patho of the urinary system. Okay. And I'm going to go through this pretty quick because this one's kind of easy, all right? So diseases and conditions of the renal and urological system can cause an acute abdominal pain. And it can be from mild to severe, right? Just like anything else. Usually when we're going to get these patients, it's going to be supportive, but we just need to recognize if it's going to be something that is critical that we need to deal with, right? UTIs, normally not that terrible, unless you're geriatric, and I'm going to talk about that in just a second. So it usually develops in our lower urinary tract where bacteria enters the urethra and then grows. Remember when we talked about how women wipe, there's a reason for that. We don't want the normal flora from the anus to go into the vagina, thereby creating a UTI when those two mix. So we know that these UTIs are definitely more common in women. They're also definitely more common in pregnant women than they are women that are not pregnant because the normal flora is interrupted. Okay, this is also known as bladder inflammation or cystitis, and it usually develops, I already talked about that, hold on. Occur in upper urinary tract when the lower UTI goes untreated, and usually you're gonna have a lot of pain associated with that, but some women don't have pain. Can lead to pyelonephritis or abscesses, and that's going to be very painful. It can eventually lead to reduced kidney function, and in severe cases, and more commonly in the elderly, can lead to sepsis. So now let's go to the elderly real quick. It can lead to sepsis. They can be perfectly fine, an 80-year-old person sitting up in the nursing home, able to feed themselves. They know what day of the week it is. Maybe they're in the nursing home just because they need extra help, right? But they are an A&O times 4 person. They are perfectly fine. And then the next day you come in, they may or may not even be running a fever, and they have no idea where they are, who they are, or what's going on. They have, and it causes sepsis. And when you get sepsis, you have a change in your mental status. And it may not necessarily be that they're unresponsive, but they definitely do not know. They're not A&O times 4 is what I'm getting at. So that's the very first thing when I go to an elderly patient and they're normally perfectly fine and they're not right today. I usually ask, okay, do they get up and use the restroom, or are they incontinent? And if they're incontinent, my very next question is, okay, when they void, what is the color in their diaper, or whatever case may be? And you can go from there. So that is a number one reason for elderly patients to get sepsis is from a UTI, okay? And Bethany even clearly stated it right there for us as well. So common symptoms of a lower UTI: painful urination, frequent urge to urinate, difficulty in urination, pain that begins in the visceral discomfort and become extreme and burning, cloudy urine with a foul odor. Now, let me go back up here real quick. The frequent urge to urinate. Remember how we talked about how the ureter is all the way at the bottom? Okay, so like this is the bladder, right? And we have the ureter and it's right here, okay? Or the urethra, right? So when we have a UTI, we'll just make this a man, okay? So the urethral opening is right here, and let's just say that we get an infection and it goes up the urethral opening to the bladder, right? So we're here at the bladder at the very beginning. So when we have inflammation, it causes swelling, right? So our receptors that are around the bladder become inflamed, making us think, oh no, my bladder is huge, it's about to pop open, I got to go to the bathroom. That is why you have a frequent urge to urinate. And now when you are urinating, the liquid that's coming out of your bladder, what little there is, going down the urethra, it's going over that infection and it's causing the burning sensation. So just a little side note there for something that you have. And yes, it is absolutely dark and cloudy, and it can have blood inside of it. Now, let's talk about the patho of a renal system. So they originate in the renal pelvis, that is part of the kidney. And these are kidney stones, rather. They arise when the excess of insoluble salts or uric acid crystallize in the urine. So if you were drinking a lot of sweet tea and you're from the South, you were part of the people that are in the that realm of you're going to get you have a more potential of getting a kidney stone than someone who does not drink sweet or even unsweet tea. And I'm not talking about like Earl Grey. I'm talking about Louisiana, okay, or whatever else there is, okay. So we don't. And I'm not saying everybody that drinks tea gets these, but these are some of what we're talking about, that insoluble salt. There's an excess amount of that. And so that's what crystallizes. And you'll hear them say, don't drink certain canned drinks. Okay. All right. So, and it's also from insufficient water intake as well. Calcium stones are our most common, most frequent in men, and there is hereditary component there. Occurs in patients with metabolic and hormonal disorders as well. And you're going to get greater pain the higher the blood pressure. So you're going to have severe pain, but the higher their blood pressure and pulse, excuse me, I apologize. Let me back up. That's part of our fight or flight response. When you have a pain of like a 6, you're going to be maybe slightly tachycardic. You have a pain scale of a 10, you're going to be tachycardic. Like you might be popping out at 110, 120 even, just depending, okay? So you just have to go by what you see and what the patient tells you too, okay? Because they can be on certain medications, guys, that their heart rate never moves. So I don't want that to be like the one sign and symptom that you're looking at. I just want you to know that if you have a patient that has an increased blood pressure and an increased heart rate, and they say they're in pain, this is why. But if they're on anything that's a beta blocker, which ends in LOL, they're not going to have that, okay? All right, AKI, or acute kidney injury. That's going to be a sudden decrease in kidney filtration. Guys, this is not good, all right? And this is something y'all need to know. So this whole next couple slides, I would pay very close attention to, because you will be tested on this, all right? This sudden decrease in kidney filtration, it is accompanied by an increase in toxins in the bloodstream. Why? Because the kidneys filtrate out all these toxins, right? Well, now our kidneys are no longer filtering correctly. So we're going to get an increase in toxins. This is not good. This can be, and it is often reversible, but only if it is diagnosed immediately and treated immediately. If your urine output drops below 500 milliliters, this condition is called oliguria. You need to know that. For testing purposes, you may see it on the quiz, you may see it on the module exam, you may see it on the final, but you will see oliguria, just like you're gonna see hematemesis, or hemoptysis, you're gonna see all of those things. Make sure you know these names, okay? If the urine stops completely, that is anuria. Anuria. It is the absence of urine. Anuria. Whenever AKI occurs, the patient may experience generalized edema, even acidic backup. They're going to have high levels of waste products in their blood, and if left untreated, it can and will lead to heart failure, hypertension, and metabolic acidosis, and none of those are good, okay? Now we're going to go to chronic kidney disease, okay? So CKD is a little different. So we had acute, right? Now we have chronic. Chronic is progressive and irreversible. And what happens here? It is the result of permanent loss of nephrons. And it takes months to years before this happens. It's often caused by systemic diseases such as hypertension and even diabetes, okay? So that's not cool at all. Now, I will say that there are some congenital disorders that you can read about that, and some infections. Nephrons of the kidneys become damaged and cease to function. So when that happens, if we can't urinate out our waste products, where does it go? It goes in the blood. And so now we have a systemic complication that's going to develop, and that's going to be hypertension. It's going to be congestive heart failure, anemia. We're going to have electrolyte imbalances, and our patient will eventually die. Okay. Here are here are signs and symptoms. AMS is one. You're going to have seizures, coma, lethargy. You guys can read the rest of this. Tachycardia is going to be a big one, okay? So let's go to end-stage renal disease. If left untreated, guys, AKI or CKD will progress to ESRD. Yeah, I know I said a lot. So acute kidney or chronic kidney disease will progress to end-stage renal disease. You need to know what AKI stands for, you need to know what CKD stands for, and you need to know what ESRD stands for. Okay, because you're going to see ESRD. You're not going to see end-stage renal disease. And I want you guys getting on there on a test and like, what in the world is this? Okay, please, I'm telling you guys to underline, highlight, make a notation anywhere. Okay. You good? Okay, get out of the drama club, kid. Sorry. Shh. Sorry, God. Okay, so toxic waste materials are going to build up in the patient's blood once again, but now it's fatal. They have to have dialysis or they have to have renal transplants. And to be completely honest with you guys, if you have a patient that has had AKI that led to chronic kidney disease that led to ESRD, they can be on that list to get a kidney, but for the most part, they've already proven that they will not change their habits and their lifestyle, as they get on the very bottom of the transplant list. So you have a lot of people that are on dialysis right now because of that issue, and they're going to be on dialysis, and it starts out at two times a week, and sometimes it goes to 3 times a week. Okay, and what that's doing is it's simply taking the blood and filtering out all of the toxins that the kidneys just cannot do. Okay, so you're going to have initial signs and symptoms of your confusion, and I'm not going to go through all of these, but chest pain. You can have bruising as the toxins begin to get more. Nausea and vomiting. You're going to have some muscle twitching and tremors, and that's because of the calcium. And then you're going to have pale, cool, and moist skin, edema, and ureatic frost. And that's going to be like, and you can see this especially like on their ankles. And you can see it's like some sort of it's almost like a dusting of something. And that's what the ureatic frost is. And it's like, you just want to kind of brush it off of them like, oh, what is that? And you're going to usually find that around I see it on their ankles a lot. It's going to be on their face and places that are going to be more, have more edema. All right. You're going to have hypotension, tachycardia, pericarditis, pulmonary edema are also very common. And in late stages, you're going to have seizures and then coma, and then they will ultimately pass away. So let's talk about the pathophysiology of the female reproductive organs. And if you guys will bear with me for just another minute, I have an 8-year-old in this room, and I do not want her to know the rest of this. So hold on. Okay, guys, so gynecological problems are a common cause of acute abdominal pain. I'm going to go ahead and tell you this very quickly. I had a conversation with a few firemen the other day, and we were talking about going to calls with women who have abdominal pain, and we were talking about how the age has decreased for childbearing age. So I will say that it does say here in the notes, always consider a woman with lower abdominal pain and tenderness may have a problem related to ovaries, fallopian tubes, or uterus. And what that can be, obviously, when we're talking about our fallopian tubes, is that we have had an egg implant there. And it has been seeded by a sperm, and now the woman is having an ectopic pregnancy. And that is extraordinarily dangerous for the woman, and she has to go and have that taken out surgically in order to not die. And we were talking about how the age has changed. Even in your newest book, it may not even tell you that the now national average for a female beginning her menses, which is the first monthly period that a woman can have, is now at age 10. Now, I'm going to impress upon you that that is the national average. And so what happens when we have an average? That means there are some that are higher, maybe 12, right? Or could be 8. So you have some 8-year-olds walking around right now that have started their monthlies, and they can get pregnant, okay? So I want you to understand that when you go to a female of childbearing age, all the way down to 8 years old, which is my child that just walked out of here, who has a boo-boo on her arm because she fell and she has an ice pack on it, okay? Think about them. She's 8 years old. She's not supposed to know these things, all right? If she were that child and she had begun her menses, yes, she is childbearing age. So these are questions that have to be asked in a very you don't just walk up and say, hey, are you sexually active to an 8-year-old in front of her parents? Obviously you can't do that. So it gets a little tricky when we're talking about stuff like that. And you can feel that out on a scene on how to progress when talking about it. So I had to tell you that because that is something that, unless I had looked that up recently, I would not have known that had changed. Okay. Now, I will say that usually when a woman has pain, it's because we're having a release of an egg from our ovary, and it's just normally part of it. And usually you're going to have it on the left or the right side. Sometimes a woman may only have right-sided pain. She may only feel it every other few months or what have you, or it might only be on the left side, or it might take turns, or it might be both. So it just, we're weird. It's okay. So let's talk about PID. A common cause of acute abdomen in women is pelvic inflammatory disease. It is an infection of the it's an infection of the fallopian tubes and the surrounding tissues of the pelvis. So acute pain and tenderness in that lower part of the abdomen may be intense and is accompanied by a high fever. And you're going to see something called a PID shuffle. And it is where the pain is so intense in the lower abdomen that a woman cannot physically pick up her feet. So she will shuffle her feet. She'll just move them back and forth instead of up and down like a normal person with a gait. So that's a telltale sign. Okay. Ectopic pregnancy, I already talked about that. That's going to a fertilized egg implants outside of the uterus, usually in the fallopian tube. And when that ruptures, massive internal hemorrhage, acute abdominal pain. Generally, it's going to be on one side for obvious reasons. But a fallopian tube can only support the growth of a fetus and placenta for about 6 to 8 weeks, and that's it. When that ruptures, it can kill the woman, causing hypovolemic shock. So that's a big one. Epididymitis and orchitis, that's going to be infection-caused inflammation of the epididymis, and this is going to be male. With orchitis, it's going to be the infection causes one or both testes to become enlarged and tender, okay? And these are complications essentially from just a male UTI, okay? Let's see, swelling can also occur in the groin on that affected side. It even increases, pain increases in the bowel movements. So there's going to be fever. There's going to be a color change in the urine, a foul odor, and all of those things. And we're just going to support this patient when we take them to the hospital. Priapism is a painful, tender, persistent erection. And this can result from a lot of different reasons, leukemia and tumors, a blunt perennial trauma, spinal cord injury, and even use of cocaine, certain prescription meds, and even drugs for erectile dysfunction. Remember, they said if you have an erection lasting longer than 4 hours, you need to call a physician. You need to go to an ER. That's called priapism, okay? And it is not okay. And it hurts. I have had a couple of patients that have been hit in the head and they've had priapism. And that's something that you guys will check when you deal with trauma patients to see if a man has an erection, because if they have a positive erection, then that could mean they have a spinal cord injury. But when we're doing this, we're maintaining the patient's privacy. We're not going to make an assumption about the cause of why this is happening. We're not going to make fun of a man, just like we don't, hey guys, it's 2024, okay? We're just not making fun of people. That's all there is to it, okay? And we're not going to point it out and go hee hee. All right, we're adults. If a man has priapism and it's lasted for hours, or if it's because that any of those reasons, it is painful, and I'm sure it's also embarrassing as well. So benign prostate hypertrophy, or BPH, you will hear it called that. Please write that down somewhere in the margins, underline, highlight. BPH, it's age-related, non-malignant, non-cancerous enlargement of the prostate gland. A ton of men have this. Literally, it's 50% of men older than 60 years of age have this. It can be asymptomatic, or it can lead to that difficulty urinating and starting the urine flow. So it takes them a minute. It can be a slow and weak urine flow. Once it does start, it can be an incomplete emptying of the bladder, increased urination at night. It can even cause urinary retention. Okay. Let's see. Testicular masses. These rarely require pre-hospital treatment, but you may find somebody that finds one and freaks out and has some hyperventilation, and you might have to go get them. I don't know. So it is what it is. These may be painful, may not be painful. If it's painful, it may radiate up into the spermatic cord. It can be localized to a specific scrotal point. But most are just benign cystic masses. Testicular cancer usually presents as a painless solid lump in the testicle, the same way that breast cancer is generally painless as well. So you have to just watch that, okay? Testicular torsion is a medical emergency, okay, period. Twisting of the testicle on the spermatic cord, and that's where it's like suspended. All right. It is associated with sudden onset scrotal pain and swelling. It is absolutely a medical emergency if the twisting of the vessel reduces blood flow to the testy. So can you imagine if someone's testicle, and I'm not trying to make anybody upset here, but if it is twisted to such a degree that it is cutting off blood supply, that is an emergency, okay? Torsion may occur with or without blunt trauma, a testicular lump, or it could even be blood in the semen. It's usually unilateral, so it's only one testicle at a time, and you just really have to watch the reduction of blood flow on those. All right, so let's go ahead and take another break, and then we will be able to finish this up. It is scary, Mark. That I'm not a man, but that does scare me, okay? For men everywhere. All right, guys, I'm going to take a 10-minute break. I am going to go get something to drink, and then we are going to finish up. We got about 30 slides to go, and we should definitely be done by 9 o'clock. So I'm going to go through here and just make sure everything has been answered. I'm almost positive it is, but I want to catch up too because I want to see what y'all are writing. So if you guys will just give me a second. And let me start that. All right, guys, see you guys in 10 minutes.
Yep.
Okay. I think Patricia's still on break, but I was reading your message in the chat. I don't know if that's one that I really personally dealt with. As we all know, there's a million things out there that, when we respond to calls that it could be, and there's gonna be those things that we don't always deal with. But yeah, was that a special needs patient?
Yes.
It was? Okay. Was he at all verbal or anything like that? I'm just curious. I'm asking all the questions because it just intrigues me.
Yeah, we got on the call, and I want to say I was by myself on that call, and she kind of explained to me what was going on. I was like, well, I really can't, nothing I can really do is just as a basic. And then it was to navigate with him. And when I reached, I was talking to him, letting him know to take a blood pressure and stuff. As soon as I went to grab his arm or to touch his arm, he snatched my hand and brought it up close to his mouth and was touching. It freaked me out for a minute, but it was just there was nothing really I could do for him. It was just, it was a weird call.
Right. No, so I'm actually reading it right now. It says it's an inflammation of one or both testicles. Bacterial or viral infections can cause this, or the cause can be unknown. It is most often the result of a bacterial infection, such as an STI. So that's a kind of an eyebrow raiser. I can see why that would kind of stick out in your brain.
Yeah, and that was quite a few years back. I did that, and it was just kind of weird. It was just I saw the word, and I went to reading about it. I was like, oh, and it's just like one of those things I always wondered, like, what would have caused that, and if that was even what it was. You know what I'm saying? I mean, I talked about it with somebody else, and they were, they were like, man, as a young EMT, and kind of getting into it, it was kind of like, it was just you try to figure out what it was or what may have caused it.
Right. So just from my experience, and again, my experience isn't everything, but I will say your special needs patients, I think there's a special pops lecture coming up later on or something like that. Anyway, it's hard to tell with your special needs patients what's going on specifically because of the obvious, the communication gaps, all that kind of stuff. But like, it is very hard to get that population to clean and do hygiene like they're supposed to. And then even when they do figure it out, there is no it's hard to check that because they know, either they've been taught that, hey, this is a private area, nobody comes here, and they can get very
exactly.
But
do I want to look at it? Do I?
Yeah, some of them are very, very self-conscious. Yeah, some of them are very, very, very self-conscious. So I mean, that's a whole nother bridge that you have to Patricia, I'm laughing. I'm sorry.
Yeah, we all want to know now, Patricia.
No, but seriously, that's why I'm bringing this up, is because special needs is near and dear to my heart. And if they, I have a special needs baby in my home. So, and he's very, very private. Like, he does not want anybody up in his business whatsoever. So,
well, and this guy would talk, he would conversate with me like a little bit within reason. It was just, he knew, I don't know, it was just an odd call.
Well, it's an awkward situation.
Mom called for help because she didn't know what to do, and she's like, they're swollen, and I'm like, okay.
Yeah. Well, the other thing about that is you don't know, some of them haven't been taught what's appropriate and what's not appropriate. And if some family member is taking advantage of them, then that's a red flag. And that's something that as providers, we do have to pay attention to. So, I mean, you go from one extreme to the other, from super, super private, protective, all the things. But then you go to the ones that don't have a clue that, them being taken advantage of is wrong. And, then that could be the cause of the infection.
Yeah, so, and just in general, when he grabbed my hand and brought it up to his mouth, it's like my other hand jacked back like he was getting ready to bite me or something. Like I didn't know what to do. It was kind of just
They will
scared
usually
me for that moment, but then I figured out what he was doing.
Yeah, usually if you kind of gently redirect that population, you will be fine. They're reading your body language more than your words. So I don't know. Interesting conversation. So that's all I got, really. It's just I learned something tonight too.
Well, I'm glad everybody could learn something tonight. The new ARES website just went live during the break. And so I, of course, being the person I am, I'm going through trying to find what's going on. Like, what are these little, I'm not afraid to click something. If I break it, it'll be fine. It's the internet. We can fix it, right? And so I'm going through and I find that ARES has a podcast, you guys. And so I'm sitting there and I'm just texting Rob back and forth like, can I please be on it? Can I please be on it? Can I please be on it? Like, I am not ashamed to beg to be on a podcast at all. And I was kind of being a little jealous of some of the other male instructors. And I'm like, have you met me? I am passionate about EMS. I want to be on the podcast. So now he's going to have to delete all this out of the recording, and I don't care. But he told me I could be on the podcast, so I was celebrating. So my apologies. But you will definitely not. No, you will. You will find other people that are just as passionate about EMS as I am. I am just super vocal. I love the fact that we have the ability to go to people's homes, crash sites, and we get to be that person that saves them from the clutches of death in some cases. Or we might just be that person that cares enough to touch their hand while we're going down the road and give them a shoulder to cry on, or whatever the case may be. And I love being everything in between. I love learning history from my geriatric population on dialysis transfers or just regular transfers. I love every single aspect of EMS except for the fact of the back-breaking portion of it, maybe. But that's pretty much the only thing that I don't like about it. So I'm super passionate about it. Anyway, all right, so sorry about that. I got way off subject. Let's get to the pathophysiology of other organ systems. So I want everybody to do me a favor, and at home, I want you to take your fist. I want you to close your fist, okay? That's the size of your heart, okay? Now, the heart has an aorta that comes off the back of it, comes off the top, makes an arch, and it goes behind. It goes behind the peritoneum. So I want you to understand that at the smallest portion of where like your wrist is, that's the aorta going all the way down, and it travels behind just in front of, or oh no. Okay, it lies, it goes directly in front of the spinal cord, or the spine itself, and so it's protected that way. And it's really large, okay? I mean, it's like that thick. And so when it has an aneurysm, when it has a portion, because it's been under so much pressure that it has like a small bulge in it and it pops, you can imagine that all that blood flow that's coming from the left ventricle that's being pumped into the aortic arch, going into the abdominal aorta, how much blood can be lost in even a very small dissecting aortic aneurysm. Okay, so with that being said, it's rare, but it does happen, and it happens mostly in our older people because of those weakened areas. And so an aneurysm, by definition, is just a swelling or enlargement of a part of an artery resulting from the weakening of the arterial wall, and it is because it's been under so much pressure over so long. That's why your elderly patients are more likely to have a AAA, which is what we're talking about here, than anyone else. Okay, so it is a slow thing. If you have a tear or a rupture, massive hemorrhage will occur, and your patient is going to go into hemorrhagic shock. And if they don't get to a hospital immediately, they will be into profound shock, and then they will die. Okay. So now let's talk about hernia. There is the protrusion of an organ or tissue through a hole in a body cavity. And that's just kind of where, hey, this organ doesn't belong in there, but it's kind of moved its little way into another area where it shouldn't be. And sometimes these are congenital defects kind of around the umbilicus. And in some cases, it's even a weakened area, such as in the groin. It can be a weakened area even in the diaphragm. You can have intestines. If you've ever listened to breath sounds and heard intestines, it will freak you out. Because that has happened before. Yes, it's a tearing around the shoulder blades. It's called a AAA, and it is a pulsating mass in the abdomen. If you see a mass, you know, we talked about gentle rotation. We're not bearing down. one of the reasons that if you see a pulsating mass or you feel a pulsating mass on an abdomen, do not touch it and gingerly take this patient to the hospital as quickly and as less jostly as possible. That's not a word, but it is today, because we don't want to sit here and move them back and forth and go over every single crater in the road. Okay, now I'm from Mississippi. We have terrible infrastructure here. I don't know how the roads are where you're at, but we are pothole city in all of Mississippi. Okay, so when we go down the road, we had to be very careful. So I did see that. I just want to grab it real quick and talk about it. Okay, so once again, it doesn't always produce a mass or a lump for a hernia, but it's just a natural weakness, okay, that's there. Reducible hernias pose little risk and can be pushed back in, and they can be pushed back in without. Now, earlier, someone said something about how do they put it? Can the intestines twist? Yes, they can. It's called strangulation. And incarcerated hernias may become seriously compressed by surrounding tissues, eventually compromising some of the blood flow. And in some cases, it can cause this strangulation even, and it can be in all of these different areas. Serious hernias can have the signs and symptoms of a formerly reducible mass is no longer reducible, pain at the hernia site, tenderness when the hernia is palpated, and red or blue discoloration over the hernia. Let's see. Moving forward, let's go into scene size up, okay? Sorry, I'm sending my children a text. Okay, they are being incredibly loud. All right, so scene size up. First and foremost, scene safety, right? Standard precautions, because we don't know what we got. MOI, NOI. There may be some violence necessary. Get PD or SO en route. If the patient complains of a GI symptom, suspect the release of even a biological or a chemical agent. Different things of that nature, okay? We have to think about everything, right? Absolutely. So what about our primary survey? Think about our common signs and symptoms: irritation, inflammation of the peritoneum, right? So is it local, diffuse abdominal pain, tenderness? Is the patient quiet? Are they guarding the abdomen? And guarding doesn't necessarily just mean they're holding like their arms or a pillow in front of it. Guarding also means that when you go to palpate that area, you know, when we palpate, we don't go to the area that hurts first. We go to the area directly beside it, and then we move in a way around it, okay? And so I like to go clockwise. Some people like to go counterclockwise. I don't care how you do it. Just don't go to the one that's painful first. And the reason for it is because if you go to the one that's painful first, the abdomen is going to contract, also called guarding, okay? So you'll be doing your palpating and everything else, and you're like, why is the entire abdomen hard? Well, because they're contracting their whole abdomen because you touched the painful part first. So we don't do that, okay? So they can have rapid and shallow breathing, referred pain. Remember, we talked about the shoulder pain, anorexia. They can have nausea and vomiting, diarrhea, hemoptysis, or hematemesis. I'm sorry, not hemoptysis. Hematemesis is vomiting blood. Hemoptysis is coughing up blood. So I apologize for introducing a different word to you guys without the definition. And distension in the abdominal region. Patients experiencing renal or genital problems may have some of the same signs and symptoms as abdominal problems. So location of the patient can provide clues, and GI problems really do affect the breathing directly. So we still want to ensure that where our ABCs are good, and we're still going to go through that anyway. The only time that you're going to have maybe a breathing problem here is going to be from a severe complication, such as like if you have an esophageal varices, okay, Mallory-Weiss tear. We think about those, right? But you also may have a patient that could have aspirated. That can affect our ventilation or oxygenation, and the patient may show shallow or inadequate respirations because deep breaths often do intensify that pain, right? Okay, thank you, Deborah. I'm glad y'all can't hear them. Okay, primary survey, continuing on, we've already done our A's, we already done our B, let's go to our C's. So pulse rate, depth, and quality, what of our skin temperature, condition, and do we have shock? Do we have any idea that there could be shock? Check pulses in both arms because the differentiation in pulse strength may indicate an aortic dissection. So if you have different strengths and even different pulses, definitely notate that, okay? Many GI diseases involve pain and or hemorrhage, so we're going to worry about hypovolemic shock. We're going to worry about infectious shock, which is sepsis. And we are going to worry about going ahead and giving some high flow O2, keep their patients warm, and keep them in a position that's dictated by your local protocol, okay? And obviously prompt transport as necessary. Then you have orthostatic vital signs. So you can have two different patient positions will help you determine the extent of that. So standing, laying down. Oh, pardon me. Sorry, guys. So if they are standing or sitting or laying down, that can change their blood pressure and heart rate and even their respiratory rate. Thank you, guys. Thank you, Lindsay. Okay, use caution to avoid a loss of consciousness when you're doing this. And when you have them change positions, make sure you were there to catch them just in case, okay? Thank you, Deborah. Okay. So transport decisions. Obviously, when we're making this decision, we want to know all of the stuff from our primary assessment before we ascertain, hey, this is a rapid load and go, or we can stay and play and kind of figure out what's going on, right? So if we're rapidly transporting, these are patients that have a problem with the ABCs, we have suspected internal bleeding, or we just have a general poor impression of our patient, okay? Let's say that everything else is perfect, but our patient is pale and diaphoretic. Shock, let's go. We're not staying and playing, we're loading and going, okay? So it can be just one thing just just abnormal to you, okay? And that's gonna dictate that they're gonna go ahead and go, okay? Ensure that the ride during the transport is as gentle as possible. Once again, we wanna make sure that we are ensuring that smooth and steady drive. History taking, our OPQRST is so important. Remember, we want to know when it started. We want to know what provocates this. Does anything make it feel better? Does anything make it feel worse? What is the quality? Tell me, how does it feel? Remember, we're not leading our witness on the witness stand, right? We're not giving them what does that mean. You can literally sit here and say to two different patients, say, is it crushing or burning? And they're going to say crushing. You take the exact same patient on a different day and say, is it burning or crushing? Exact same pain. And they're going to say it's burning because you are leading them. So you can tell them, just tell me what you think that pain feels like. It's okay. Just use your own words. I'm just going to write down what you say. It's just going to help me. That's all you have to do. Just kind of explain. You just tell me what that pain feels like. Okay. Region and radiation. Is it set in one place? Is there referred pain to the shoulder? Is there referred pain to the back? Severity on a scale from 1 to 10, 10 being the worst pain you've ever felt in your life, 0 being none at all. Where are you on this? If it's a kid, use the Wong-Baker timing of pain. Does it come and go, or is this pain constant? Okay. And look at your table 20-4 because that's going to kind of help you with the types of pain. Sample history. You guys already know this one, but signs and symptoms, allergies, medications, past pertinent history, last oral intake and events leading up to, all of those are going to be so relevant and help you do what you're trying to diagnose, okay? And a field diagnosis is just something that we think is going on, right? Because we can't really diagnose anything because we're not doctors, okay? So when did the nausea and vomiting start? Like changes in bowel habits or urination, weight loss, belching, flatulation, anything specific to that particular complaint. If chest pain is reported, also use the OPQRST and ask females all about their last mental period, a last oral intake. Never give anything by mouth at this point and check for trauma. Now, when I was going through EMT school, now I'm going to talk to my EMTs real quick. I was like, why in the world do we care about the last oral intake? Why? I don't understand. And it wasn't until like my second C-section, because it was an emergency C-section, and I just gotten through eating hibachi, like 45 minutes before I'm having an emergency C-section, like not a joke, that I realized why I needed to know when the last oral intake was. The poor anesthetician behind me could not suction adequately enough to the point where I took the yonker out of his hand and suctioned myself. Everyone in the operating room laughed. I am that patient, okay? If you can't do it the way I want it done, I'm going to do it myself. And that was when I realized I had a problem. Now, with that being said, if you have a patient that's having an abdominal injury, issue, potential bleeding inside, don't you think they're going to go under the knife? Absolutely. And when they are laying flat, what do you think is going to happen when they're opening up someone? Even laparoscopically, that patient is going to vomit. And so we have to protect the airway as best you can. So when you have a patient that has the potential of having some sort of surgery, which every single person that we pick up, by the way, has the potential to have surgery, we need to know when was the last time you ate or drank anything, okay? So if it was lunchtime, then and it's now time, well, then that was 8.5 hours ago when I allegedly ate or drank anything, right? Or I can say, I've been drinking since you walked in the door, okay? So the suction when you have a spinal block, I swear, because you constantly feel like you have to vomit here. Yes, Sierra. Okay, now I'm going to get back onto this. Okay. But yes, absolutely that. Okay, so secondary assessment, guys. This is information gathered in the history-taking portion of the patient assessment that may be used to focus your physical exam on the abdomen. Remember, the abdomen is normally soft and non-tender to the touch. So pain is going to be our most common associated sign and symptom, okay? It can be sharp and localized, or it can be diffused in vary in severity. It can be localized. Your patient can have board-like muscle spasms, or it can be diffuse, okay? There's a whole bunch of different things. A patient could be quiet, they could be screaming. So it all just depends on what you have here, okay? Remember, when we're doing our abdominal assessment, you're not just going to walk up to a person and start touching them, are you? No, first we're going to introduce ourselves. Hey, my name is Patricia. I'm from the ambulance company. I'm here to help you. What's going on today? What brought us here? We're going to talk to our patient. We're going to get our ABCs, general impression. We got all of these things. Okay, now, hey, I am going to go ahead and lay you on your back. And what I'm going to do is just called an abdominal procedure. I'm just going to touch you all over your belly, and you're going to tell me if any of this hurts or anything feels funny, okay? And I'm going to remember where they said, hey, I hurt right here, and I'm going to start lower and work my way back around in a clockwise fashion. That's what I do, okay? But if you have a patient that you need to tell them, hey, I'm exposing the abdomen, especially in teenage girls, okay, we want to make sure that they understand we're going to cover the big parts, right? We're not going to, we're not going to take everybody's shirt off. That's not cool, right? Palpate that abdomen very gently and look for the patient's response too. And that's a big one. You guys can continue to read about the rest of that. What if you have a high respiratory rate with a normal pulse rate? Blood pressure may indicate all of these improper ventilation. So remember, high respiratory rate, pulse rate with signs of shock may indicate a septic or hypovolemic shock patient, okay? When available, use pulse ox and an NIBP or non-invasive blood pressure device, okay? Reassess. Okay, look. If you're dealing with somebody with an abdominal problem, you're going to be reassessing every 5 minutes because, guys, I need to know what those vital signs are doing. I need to see, are we trending down? Are we trending up? Is my patient in shock? What is going on? Is what I'm doing procedurally helping this patient? Have I started an IV and started giving them a little bit of normal saline, lactated ringers? What am I doing here? This is for my advanced people. How am I helping to assess and change what's going on with this patient, okay? If I have done anything with the airway, I've got to reassess that. Breathing, if I'm giving them oxygen, reassess. Have I stopped bleeding anywhere, okay? I got to reassess all of these different things. So we reassess every 5 minutes in an unstable patient and every 15 minutes for a stable patient. If you feel like you need to, if this patient is so bad, you need to go ahead and get that paramedic backup. Go ahead and call and have them coming. Because if a patient is in shock, you're going to need that extra upper level care, okay? And some of the other questions that you can talk about to your patient and things that you ask yourself, especially when you're documenting, think about this. Has my patient's level of consciousness changed? Are they more anxious, less anxious? Is the appearance of the skin changed for better or worse? Has the pain gotten worse, better? Bleeding, increase, decrease? What's going on? So all these different questions that you can ask. Okay, emergency medical care, and we're almost done, guys. Yay! Okay, so acute abdomen is a serious medical or surgical emergency. Remember, surgery, okay? Last roll intake. Provide prompt, gentle transport. Do not delay. I'm not saying jostle them going down the road, going lights and sirens, get them to the hospital, okay? Before transport, we're not diagnosing. There's 400 different things that could be going wrong. We don't need to know that. We just need to know that they're in pain and what our signs and symptoms are, and we can kind of narrow the field, okay? If I'm taking a man, it's not ectopic pregnancy. Great, I've already X'd one off. If I'm taking a female, it's not testicular torsion. Great, I already X'd one off. But now we can go into something even further, because if we know what the signs and symptoms are, we can kind of generally get an idea of what's happening, okay? Make sure that you take care of your ABCs as you're going. Anticipate vomiting. Go ahead and get your vomit bag. Emesis bag. I've never called it an emesis bag, but go ahead and get that ready. I am a social puker. I puke, you puke, I puke, we all puke. So you get an emesis bag, I get the trash can. Administer your 100% supplemental O2, but be ready if they are on a non-rebreather and they start to retch, you better be ready to take that off. So I like to only give nasal cannula with patients that are nauseated. Okay, that's one thing. Yes. Okay. Thank you, Jafana. Okay. But if you do, be prepared to give that 100% supplemental oxygen. Be prepared to bag valve mask that patient if necessary, especially in a reduced tidal volume, because they need that. Okay. Do not give anything to the patient by mouth ever. Document all of your pertinent information on your OPQRST. Anticipate treatment of hypovolemic shock. Advanced EMTs, you're going to go ahead and get IV access, and you're going to give a 20 ml bolus of an isotonic crystalloid if the patient presents with signs and symptoms of hypovolemia. Otherwise, we're just going to maintain that fluid at a KVO rate, which is a keep vein open. You may even see it as TKO, which is to keep open, but keep vein open is the most correct form, especially now. If the patient does have a UTI or a kidney stone and kidney function is present, you can administer a bolus of fluid, but be wary of that, okay? Remember, if they have ESRD, they're not going to create any urine at all. They're going to have anuria. So when you were giving them a bolus of crystalloid medication, you need to understand what you're doing to that patient, okay? Make the patient as comfortable as possible. Of course, we're going to conserve body heat with blankets above and below. Gentle transport, once again, monitor our vital signs and consider for a paramedic backup. If we have PID, pelvic inflammatory disease, we may be, pain could be very intense and accompanied by that high fever. Remember, that's going to be lower part of the abdomen is going to be painful. Go ahead and get into the emergency department very quickly. Consider ectopic pregnancy in any female of childbearing age, okay? Pneumonia, that can cause ileus and abdominal pain. It does depend. And of course, an inflammatory response affects the abdomen, and treat and transport like you would any other patient. Acute signs and symptoms with shock could signify an aneurysm, requires prompt transport, and avoid unnecessary and vigorous palpation of the abdomen. So this is more towards like if you feel like they have an aneurysm, not just a AAA, but an aneurysm, period. If you feel like they are bleeding internally, once you find that, stop. There's no need to continue. Hernia, we're going to transport AKI and CKD. That is a life-threatening emergency. It can definitely cause, if they are not handled quickly, they can die. So ABCs, be alert for hypotension and pulmonary edema. So if they have pulmonary edema, remember, we may have to put them on CPAP and provide prompt transport. Renal dialysis. In chronic cases of your ESRD, renal dialysis is the only definitive treatment. This is where I've already talked about the blood is filtered and cleansed, and it normalizes our blood chemistry in those patients. So you have a peritoneal dialysis or you have hemodialysis. And so those are your two different ones. In the peritoneal, it's a large amount of specifically formulated dialysis fluids are infused into and back out of the abdominal cavity. And you see a lot of people at home that can do that, okay? They have machines at home that do this while they sleep or maybe not. So it just depends. But fluid's going to stay in the cavity for 1 to 2 hours. It's effective, but there's a very high risk of peritonitis. So, but like I said, it can be performed at home. So now you have hemodialysis, and that's the one we think of. We go to these dialysis machines, right? And most patients undergo long-term hemodialysis have a shunt, and that's what's pictured here in this one. Now, this is surgically created connection between a vein and an artery, and it's usually in your forearm or upper arm, and you'll feel it. You'll see it even, and you'll see like some of the scar tissue that's over it as well. And so what happens is instead of them having to start an IV every single time, they just start the IV inside of that shunt, inside of the shunt. Okay, it's just a kind of a rubber piece of septum that gets punctured with the needles so that they don't have to continue to do it. And that's called a hemocyte. Some patients have an internal shunt, also called a fistula. And that's going to be located in the forearm or the upper arm. And yes, I think only paramedics can get the shunt. I'll have to check on that for my advanced EMTs. I'm not sure. As a matter of fact, I think that's a new one even for paramedics to get that. Because I'm not entirely sure. I think that was being taught as I was going out last time I taught paramedic. But I don't know that it ever made it into the protocols and the national standards. I really need to check that one out. So you can have an accidental disconnect from a machine. You can have a malfunction in the machine. You could have rapid shifts in fluid and electrolytes, and this is going to cause an issue with your patient. So some of those are going to be hypotension, muscle cramps, nausea, vomiting, hemorrhage from the access site. Of course, infection. That infection can lead to sepsis very quickly. Altered mentation, loss of consciousness, an air embolism. Remember, we talked about a thrombus stays put, right? But an embolism embarks. Okay, so an embolism is moving. Electrolyte imbalance, myocardial ischemia, all of these things. So when we have a sudden drop in blood pressure, it's not uncommon during or immediately after hemodialysis. However, if it is not treated immediately, cardiac arrest is definitely possible. And if our patient misses a dialysis treatment, they can have weakness, pulmonary edema, and excess of electrolytes may occur, and this is going to cause a cardiac issue. All right. If the call involves patients receiving dialysis, go ahead and start with those ABCs first. Be alert for leaking shunts. Many dialysis patients also have urinary catheters. Even though some of them may have anuria, you can ask, okay? Make all attempts to deliver the patient to a hospital with dialysis capability. Okay, that's very important because they need to have that ongoing type of treatment. Now you have disequilibrium syndrome, and this is where water will shift into the blood from the bloodstream into the cerebral spinal fluid. This increases that intracranial pressure. But when that does, because of that mild increase, it causes nausea, vomiting, headaches, and even confusion. So the patient's like, oh, what's going on? And they almost appear drunk when this does happen, okay? And it's just because that concentration of solutes has changed, okay? Anyway, this condition, like I said, it can go after several hours. The fluid eventually will re-equilibrate, if you will, between both fluids. The patient's going to improve on their own, but you may get a call for that. Like they just don't know what's going on, and that's what it is. Do you still need to go to the hospital? Absolutely. Air embolism. And here's the big one, okay? If any of the fittings and connections in the dialysis system are loose, air may enter the system, producing an air embolism. Now, I don't know how many of y'all have been to a dialysis treatment center, but all of those bells and whistles going on are ensuring that there is not a loose connection somewhere within their system, okay? We don't want that. So they do as many safeguards as they can for this. Pardon me, but if you have somebody that does have an air embolism, they're going to have sudden dyspnea, hypotension, cyanosis, and if you suspect an air embolism, go ahead and disconnect that patient from the dialysis machine immediately. Get them on oxygen and get them to a hospital immediately. Okay, guys, now I'm going to stop sharing and stop recording. Let me find the recording. Stop recording.